Not just the weight that creates the issue. When you have the increased weight, now you've got dimension problems.
But my dad ate whatever he wanted and never gained weight.
You are listening to EMS with your hosts, Erik and Matt Ball.
But actually, speaking of airplanes, I was in the middle. I'm obese, actually. We'll talk about that later.
Well, so am I compared to BMI. Yeah,
right.
I think. Yeah.
And so I'm in the middle, and I'm a little frustrated because I'm like, so uncomfortable.
Why didn't you pay
But in airplanes, though, being obese is a hard thing.
Yeah.
Or just a bigger guy, and broader shoulders. You feel like you're in everybody else's business.
Yeah.
Especially when you're in the middle.
Yeah.
So obese patients, when we treat them in the EMS environment, there are some challenges we're going to talk about.
And we treat them very often.
Yes.
We very often have patients that are obese.
Yes. So we'll break this podcast into 3 sections.
Mm-hmm.
First, we'll talk about some of the physiologic and anatomic considerations of an obese patient that we should think about.
Yep.
And the second objective was...
We got it right here.
Oh, yeah.
We got demonstrate safe lifting, moving, and transport techniques. Right. So obviously a little bit of patient safety.
Yeah, how do those anatomic and physiologic things affect the way we handle these patients?
Right. And talk about intubating these patients, how to approach that. Because you have to do things differently with that.
You really do.
IV access, we'll talk about that.
Physical exam too.
Yes, exactly.
And then the last one is the stigma of these patients and really treating them with dignity and respect. And we'll talk about some of how that can affect this patient population too.
That's right. So if you don't already like and share our podcast, please like our page, whether you're watching on YouTube or Apple Podcasts or wherever. Yeah. Definitely please follow our stuff if you like our stuff, because you can't get CE content for our stuff through the website. If you like this podcast and you want to get content for or credit for it, you got to go do that through our website.
www. Do you say www anymore, or you just say AxeneCE.com?
I think you just say Axene and
AxeneCE.com.
Axene.
AXENECE.
That's right.
That's CharlieEcho.com.
Charlie.
Anyway.
So obese patients, it is definitely a problem.
It is.
In our country.
A common problem.
Yes.
We've all seen them. It's very common.
Well, you can't not see them, unfortunately.
True. Yes.
What did we say? Over 40% of the U.S. population
is obese.
And some statistics say up to 70%.
About 3/4 of patients are either overweight or obese. It's all based on BMI.
Yeah, exactly. And BMI, like we talked about, that's not the greatest measure of actual fat, because it's just meant I'm a shorter guy, but you're a muscular guy, like guys that have, or like a lot of firemen, first responders, they're pretty muscular. Well, they're going to say, well, I'm 5'5", 150 pounds. Well, your ideal body weight max is 135.
Right.
I'm like, when I'm 135 pounds, I'm skin and bones. I'm tiny.
Yep.
It's not that I'm huge at 150, but.
Well, no, but you and I have a similar body type. We're muscular. We're kind of, we're not those ectomorphs.
Ectomorphs or mesomorphs.
That are real, violin player. I don't know. My mind is.
No, he's cello.
In our staff.
Luca.
Luca.
Yeah.
He's an ectomorph, and so
fit.
A guy like that weighs 135 pounds, and he's almost 6 feet tall.
Right. And will never struggle with weight probably his whole life.
No.
Yeah.
And then, anyways, but you and I are more of a mesomorph.
Mm-hmm. Yeah.
If I'm not careful, I will balloon. In fact, I used to
weigh a little bit of a weight problem.
A little bit of a weight problem. I love food, right? So it's easy for me to gain weight. But I've lost 50 pounds, but I'm still obese.
Good job.
And that BMI is not a real accurate reflection of me. And I still am a little overweight. I could lose some more weight, but I'm not morbidly obese like my BMI would say.
Right. Exactly.
But the point is, though, in this talk today, we're going to talk about those obese and morbidly obese patients that create some challenges for us in the pre-hospital environment. So let's talk a litlittle bit about anatomy.
Yeah.
Maybe go head to toe.
Yeah. Just to think about it, I'm 5'5", right? I'm not a big dude, right? So my body and all the parts of my body are made to operate a body that is 5'5".
Correct.
So if you took my heart and put it in your body, right, that pump is probably not going to be big enough, right, to operate your body because your heart's probably a little bit bigger than
it's going to create some strain on it.
Exactly.
That's right.
So when you gain, if I weighed 400 pounds, right, well, the structures that make my body work are not meant to do that. It's like driving a Ford Ranger pickup truck and expecting it to do the job of an F-350 and pulling a horse trailer or something with it. It's not made to do that.
And I think part of what you're talking about is more of the musculoskeletal challenges of an obese patient, where the knees are going to give out faster. You fall down, you're going to be more apt to have injuries.
The lungs, the heart.
Right.
Yeah.
But the thing is, though, it's interesting, is that there's a big difference between visceral fat and subcutaneous fat.
Right.
So, you could have a patient with a normal skinny body within a bunch of subcutaneous fat. And those people actually tend to be more healthy, actually. Their numbers look good with, their diabetes risk goes up, but they're relatively healthy. It's the ones with the visceral fat. That's the damaging fat that creates a lot of comorbidities. And it's not up to us to know which is which. They're just obese patients for us in the pre-hospital environment, and they create challenges. But just so we're clear, I think that patient with a lot of subcutaneous fat isn't going to have it's not going to have a huge impact on
their overall
directly health. On the heart and the lungs.
Yeah.
Indirectly it does because they're moving so much more weight around, so it requires more effort and more cardiac output to move, right? So those are certainly issues. But like you said, though, these patients are going to have a bigger demand on the cardiovascular system.
Yeah.
Yeah, that's huge. So, and as far as even the fat around the neck and, around the airway, the face, the neck, even the head, actually. I mean, a lot of fat can create positioning problems, can create airway difficulties, breathing difficulties. One of the major causes of sleep apnea and those snoring respirations you might hear in that patient that's unresponsive, and an obese patient in particular, is that the soft tissue gets in the way of air movement. These people need that chin lift and the head tilt, right?
Yep. One of the best reasons to get off, or not reasons, but one of the best ways to get off CPAP is lose weight.
Lose weight.
If you lose weight, then you could alleviate having to use CPAP for the rest of your life.
Huge part of it.
Yeah.
I think along those lines, if you had to do a crike on a patient that was obese, be prepared. Know your anatomy. We talk about this in our airway course, right? I mean, you may not see anything. It's all by feel potentially, but the extra tissue creates some challenges.
Absolutely.
in all of those things.
Talk a little bit more about stuff like that, like IV stuff in section 2.
Oh, yeah.
Of the different,
Oh, for sure.
Treatment management problems.
Yeah, because of all the extra subcutaneous tissue, there are a lot of challenges. And we'll get to the specifics, like you said, on that. But there's not just IV, but we'll talk about the physical exam with all the extra tissue. But if you think about it, there's a lot of challenges. I mean, even the EKG leads. The EKG leads on the surface of the skin are trying to pick up the electrical activity of a heart. And the further the leads are away from the heart, the shorter the amplitude. Yeah. So you may actually have a STEMI going on,
and you can't
but
tell.
because of the distance, you can actually impact some of the amplitude of some of the EKG morphology. You got to be very careful in treating a patient with a lot of subcutaneous tissue, a lot of distance between the electrode on the skin and the heart. Yeah. That's something that we have to consider. We also have to remember, too, is that all that extra tissue on top of the skin creates difficulties in auscultating structures, palpating structures. We'll get to that when we talk about physical exam, but these are big problems. A lot of acreage in moving and trying to assess and try to find signs of disease. That's a big issue.
So head to toe, we talked about a little bit about the head and some issues there as far as from the patient standpoint, what they struggle with being an obese patient. Now you move towards the chest, and obviously we talked a little bit about the heart and the weight on the heart and the pumping ability. You've got all this extra weight, right, which is creating a higher demand because now it takes more energy to move this larger body. And so this pump that's not designed to pump and carry all this stuff, the engine almost, it's got to work just double as hard, and so that's creating cardiac problems. So on top of the obese problems, now you're dealing with cardiac issues, right? And then we already talked about the lungs. Lung capacity. My lung capacity is made for somebody that's, my lungs don't grow as I get fatter.
You got the same lungs no matter how big you are. And the problem too isn't just it's not just all the subcutaneous tissue on top of your chest that's gravity's pulling on top of the lungs, which makes it difficult to breathe. Right. But there's also all of that visceral fat that's actually pushing up on your diaphragm and decreasing your lung volumes. I mean, even though you're right, the lungs don't change anatomically, but the functional residual capacity of your lungs will change with all that extra fat. So you're not able to take that full deep
change
breath.
For the worse, not for the better.
Worse. That's
what
right.
I'm saying, yeah.
Just like a pregnant woman, she can't take that full breath that she used to take before she was pregnant. Now these obese patients aren't getting the full lung capacity. So when they do need to dip into more breathing, they don't have the capacity to increase their lung volumes.
And so they need more, but can provide less.
That's correct.
And so that's, again, these are all reasons that if people are struggling with weight issues, like we kind of talked about in our health and wellness podcast, it's a huge reason why losing weight is so beneficial for your health, because it just compounds, being obese and overweight just compounds all these underlying health problems. Not that you just, I just don't look, it's not about looking good or whatever. You're literally causing your body to work harder with less ability to do so.
You're decreasing your longevity.
Yes.
You are going to die earlier if you carry around a whole lot of extra weight. That being said, you're at risk with obesity to so many diseases. Obesity creates a risk, we call it a comorbidity, equal to smoking half a pack a day. Which is interesting. There's other things too. They're called risk equivalents. And obesity carries, regardless of what you think, I mean, the data shows it.
The data doesn't lie.
It's not. There's a negative health consequence to being obese. So keep moving down. You get down to the gut, right? When you're dealing with a patient that's got a lot of visceral fat, these patients are at increased risk for diabetes, which creates lots of problems.
GI issues, liver problems, kidney problems, all these different things.
That's right.
Diabetes is the other thing that type 2 diabetes is rampant through the U.S. right now. And obviously we've talked about it before, that a lot of it is we're sitting a lot more, we're not walking as much, sedentary lifestyles, and we're eating processed fast foods. Not to get into the whole health and wellness thing, but that's the contributing factors. These are contributing factors. People are exercising less and eating worse than they probably ever have in history, and that's why we're having all these issues.
I think we talked a little bit about this, though, just moving down the body, the musculoskeletal issues. I mean, the further down the body you go to the knees and the ankles, you got all your body on top of that.
Ankles, depending.
But you can't forget about the shoulders and the elbows, because these folks are getting up out of chairs or falling, and all that weight is causing musculoskeletal damage. And then, you're overweight and you're in the hospital with a broken hip. It's
creates
really a whole bunch
of
of problems. I think the last part, unless you can think of another one, is that there's a higher rate of depression in the obese population. The body image stuff. It's in our society. There's a stigma. We'll talk about that with the last section, but I think that's another real thing that we'd have to mention is sometimes these patients they struggle more with depression.
And I mean, it's proven that exercise gives you a better mood, improves your mood. And so if you're not exercising at all and you're eating garbage, and most of the time people are probably stress eating, or they're eating, to get that dopamine hit to make themselves a little bit happier. Well, I don't want to go work. They don't want to do the hard things. They want to do the easy things. And it's just this terrible cycle that just keeps compounding the more and more you get into it.
And the more overweight you get and the more obese you get, the more difficult it is to really get into the gym. And the bigger the problem becomes, the more daunting the solution becomes.
Losing 10 pounds is a lot easier than losing 100 pounds.
Right. But the process for losing 10 pounds, as we've talked about, is the same. It's just may take longer, but it's one step at a time. It's one decision, the one micro decision you can make that's positive for weight loss. Over time, those accumulate. And if you can accumulate, if you can do something small that you enjoy doing, that's something you could implement into your daily routine. That's a very powerful thing. And you look back over the year and, wow, I lost 20 pounds this year. This is great.
Just by making some small changes
right.
to my lifestyle. Yeah.
So the physiologic, the anatomic realities of an obese patient create a lot of challenges for us in the pre-hospital environment. Yeah. And in our next section, we're going to break down some of the specifics now of some of these problems. One thing we didn't talk about, which we're going to get to, which is kind of cool, and I don't think a lot of people appreciate the impact that ideal body weight versus actual body weight has on medications. Huge. So we'll talk about that, along with some other things. Yeah, so we talked about the anatomic and physiologic
changes
in obesity.
Impacts of obesity. Yep.
I think, so now that we've talked about that, I mean, just in general, just having a 500-pound patient creates some challenges.
Yes, for us as pre-hospital providers. Right.
Yeah. So if we're going to deliver the care for them, just the sheer size creates some issues. Physics. Not only are they harder to lift and move, they create a very top-heavy situation on a gurney. And you get a 500-pound patient falling, you're going to break a bone. You could really get hurt.
Don't try to stop the cot, unfortunately, because that would be bad.
Well, when you're moving a patient, just you've got to be careful. You watch our cot safety.
I was just going to say, our stretcher safety lecture where we go over how to properly.
Yep.
And I mean, a lot of people don't know that. When I'm teaching our new hires, I take them through because nobody taught me how to do that. I just saw a video the other day of some kids coming out, some private ambulance guys. They were coming off a porch with a cot, and they get down and they're doing you go laterally with the cot as opposed to move it, and cot flips right over. So hugely important. Then if you have these cots nowadays, they say they're rated for 700 pounds. One good thing I will say is that when I started, the old Inferno cot that we had in our video, that was what you used to have, right? And think about, you watch the old shows, right?
Yeah.
People weren't as heavy. So two normal size 170, 180 pound guys could easily carry or pick up most patients, and everything was manual, right? And people have gotten so big that now, thank God, that we have power loaders in all of our ambulances.
That's nice.
We've got fully hydraulic power cots. That has saved unlimited amount of careers in EMS.
Backs. Oh, for sure.
I mean, back in the day, because again, I'm not a tall guy. And so when I'd have a heavy patient and I'm trying to lift that cot up high enough, oh man, I mean, I had to do that for close to 10 years before we got power cots.
Oh, yeah.
So the invention of those things has been a game changer for EMS.
No, that's huge.
And I think part of it is because of this overweight population that we're seeing, this increase in the overweight population here in the States. And so they had to create hydraulic cots to carry them. I mean, it's sad but true,
No, that's true.
So that is one thing. Yeah, lifting and moving these patients, so many back injury risks for us as pre-hospital providers. We've got to be careful with how we're lifting and moving these patients. That's a huge concern. And then once you get into the actual management and treatment of these patients, them being obese causes
all sorts of other issues too. One other thing with the weight, you have to think about the hospital capabilities.
Yeah,
some
bariatrics.
CT. If you've got a big patient, right, a chest pain patient, maybe you're thinking, boy, this patient's got a history of blood clots or whatever. If you think there's any chance there could be something going on where they need a CT scanner, calling ahead and figuring out what the weight limit is on a CT scanner at one hospital. Do you know
off the top of the head what the normal CT scanner?
I knew my hospital. And I think we had one.
Big one.
We received a lot. We were a level 1 trauma center, but we could take a lot more weight on our CT scanner. So oftentimes, what we would do is we would actually take a transfer from a local ER
else,
and get the CT scan, and then transport them back.
Yeah.
And then we've even transported patients to the zoo to use the zoo CT scanner that they would normally use large.
For elephants.
Really. Yeah, those.
That's crazy. They would transport them to a zoo to get a CT scan.
Yep.
That's crazy.
Yeah,
interesting.
But the gurneys, just the sheer weight,
like our cots, about 700 pounds for the power load cots. That's about average, I think, across the different manufacturers. But they do have, like Sister City, they have a bariatric ambulance. They have a bariatric cot, like in the ERs, you have bariatric beds. And those are typically for patients, when you're getting up 600, 700, 800 pound patients, they're going to need those bigger cots. I actually, when I was in paramedic school a long time ago, back, what do you say, when the earth was young?
Before there was dust on the mountains.
Yes. We had a large patient came from a facility, and she would not fit on the cot. We had the old little cots, and so we actually had to remove the cot and remove all the hardware off the floor of our ambulance, and we had to take our what we call a man sack, which is just a huge tarp with handles, and we had to lift it. That was the only way we could transport her.
Yeah.
And so it was like, we don't have any other options. Back then, they didn't have bariatric ambulance. They didn't have any of that.
No.
So it was like, this was our only option because she needed to go to the hospital.
Yep.
And so, creates some unique situations. We've had to cut walls out of houses to get patients out.
Well, see, that's what I was going to say. It's not just the weight that creates the issue. When you have the increased weight, now you've got dimension problems. And so doorways, all that stuff. The other thing, CT scanners. I've had patients actually, because of their body habitus, that it wasn't the weight actually that created the problem. The weight actually, they were fine. It's just that they were so short.
Oh.
It created a diameter issue where they couldn't fit in the CT scanner.
Oh, yeah. Okay.
So it's not just weight, it's also diameter.
Yeah.
You need to, some CT scanners are different. They can carry higher, patient diameters. So
and weights.
Yeah. So, some of these things, you just, it might be a good idea just to have an idea of what the dimensions are, capacities are for your local hospitals and their CT scanners, just to know where to take that patient. Yeah,
I would say if you're in a more urban area, you probably got lots of options. Know what your options are. But if you're out in a rural setting,
you may not have that option.
Yeah, you might. And then that brings up another point. You've got a critical trauma patient that weighs 500 pounds. You might not be able to fly that patient because of their weight.
Oh, yeah.
So that's a whole other factor, because everything with flight is based on weight.
Yeah, you're right.
And so that brings up a whole other issue, that if you're in a rural area, this patient that normally, this is a level 1 trauma, we got to fly him out. Can't do that. It's not an option. So what do you do? Does the flight crew come out and ride with you on ground for an hour? I don't know. But you need to have a plan. That's our point, is that you have to have a plan in place, because you will. It doesn't have to be a trauma. You could have a STEMI patient out in the county, a stroke patient that normally you would fly out. Now that's not an option. So you really got to pre-plan and think about those kind of things.
That's good.
Very important.
Well, we talked a little bit about the subcutaneous tissue that makes a crike difficult. It also makes IV access difficult too. We
had a patient one night. It was came in as a breathing difficulty, and we got there, and the patient actually coded on us. It was a smaller country house. In bed, the patient was in bed, coded in front of us. So, but the old house is built like in the 30s and 40s, small, right? Yeah. Because people size, right? Well, we couldn't. I'm sitting here looking, and I'm like, we can't get her down on the floor because then we have no room to work, right?
Yeah.
And to try to get her down and then take her down this long, narrow hallway to get her into an area where this is not. So I just made the decision. Let's just get a backboard under her, so we can perform compressions appropriately. We can start bagging and do the best that we can, and so that's what we did. But we could not get a line on her.
Yeah, I bet.
We stuck her, and then obviously I went right to the IO. The yellow 45 millimeter IO needle would not reach her bone through her tissue.
So even on the tibia?
Even the tibia.
Usually the tibia doesn't have a lot of fat.
That's why I went. I tried the humeral head. It wouldn't reach. I put that whole needle, buried it. I got a little bit of the bone. I felt like a little bit, so I went to drill it. And I'm like, okay, I think I'm in. As soon as we tried to hook the IV up, it didn't catch because she was so large. There was so much tissue.
In the hospital, we do these things called venous cut downs, or used to anyway, where we could take and dissect down into the tissue like a minor surgery
just
to
like
get down.
Doing a crike,
Yeah, so.
Well, now we got ultrasounds,
And that's actually, I was going to mention that, the ultrasound now creates this ability for us to do a better job of finding those veins. Because anatomically, we should have brought this up in the last one, is vessels. The vessels are within the adipose tissue, typically on the surface of the skin. The arteries tend to be deeper, which is good to protect those arteries, right, for an injury. And then it's also good having the venous blood out in the periphery as opposed to, but that creates some difficulties, though, with an obese patient. With all the extra tissue, it could be really hard to palpate that.
Oh, yeah. It's very difficult.
You know about where the vein might be, but if you can't feel it, it creates some difficulty. But an ultrasound.
Ultrasound changes that. And too, like the depth, again, like with that needle. your standard, 1 1/4 or 1 inch IV catheter might not reach. Yeah. So that's why, like with our ultrasound, we got, I think they're 1.5 or 2 inch. There's varying sizes you can have. Yeah. So you got to have bigger needles to be able to reach through that tissue to get to that vein.
And those veins tend to get closer to the surface in the ACs. Mm-hmm. There's less fat there.
Right.
But either way, it's the ultrasound will help you find them.
Yes, ultrasound is a good tool for these kind of patients. Airway. Let's talk a little bit about airway considerations. Yeah, I mean, these are scary patients. And typically, CHF, COPD, they're probably going to have an airway problem. Yeah. And you may have to take an airway. And so you're not going to be positioning. This is where patient positioning is so important. If you're trying to intubate these patients flat, a patient that weighs 300, 400, 500 pounds, you are doing yourself and your patient a disservice because you're decreasing your chance of getting that tube.
Yeah, that's right. When you're supine, your obese patient is supine, they've got a ton of weight. I mean, depending on how big they are, it could be 40, 50 pounds of subcutaneous tissue on top of the lungs that you're trying to bag and lift.
They're already in respiratory distress. Now you just made it worse.
That's why it's so important. And I'm not talking about airway positioning, but this does benefit airway positioning too. But ramping your patient and getting them up takes a lot of weight off those lungs. Now they're easier to bag, pre-oxygenate, and get them prepared to intubate. And then once you ramp a patient up too, it puts them in a good position for the actual passing of that tube through the cords. And whether you're ALS or BLS, it doesn't matter.
No.
Putting your patient in a good position, it's so important to elevate the head of the bed with these obese patients.
Yeah, if you're a BLS provider and you're putting your patient on oxygen because they're struggling to breathe, don't lay them flat. Think of like that CHF patient, sit them up. Yeah. How did we learn that in paramedic and EMT school, right? Yep. They sleep with pillows behind them. This is why, right?
Absolutely.
So, even if you're a BLS provider, if they're having any sort of an airway issue, never lay these patients flat. Yep. It's so bad for them.
Well, speaking about ALS things, now the BLS providers, regardless of whether or not they're giving medications or not, this is a good thing to know.
Yeah.
Medications, when you have a patient with a lot of fat tissue, there are some pharmacologic problems with that.
Yep.
Well, not problems necessarily, but just the reality of having a lot of fat tissue. So there are two categories of medications. They're either hydrophilic or lipophilic.
I'm glad you didn't say phobic.
I know.
Like you guessed.
Well, in medicine, we would say hydrophilic, hydrophobic.
Yeah.
As water-loving or water-hating.
Right.
But I think what we're going to say today, pharmacologically, with obese patients, some medications are hydrophilic or water-loving, and some are lipophilic or fat or oil or lipid-loving, right? So what's interesting about this is a medication. In fact, we've got a list, but we'll go over the details of it. I'm just thinking of one just off the top of my head. A medication like adenosine. Adenosine is hydrophilic. So when you inject it into a vein, it's not going to do much leaking out into the fat tissues because it doesn't like that.
Because we need to get it where it needs to go.
Straight to the heart and do its job.
Right.
Whereas a lipophilic medication is actually going to get out into the fat tissues and sequester or get stored out there. And multiple doses, you're going to continue to increase the amount of that medication in the fat tissues.
Yeah.
Because when medication gets into the fat tissues, it doesn't get metabolized. It just sits there. It doesn't get metabolized until it's in the blood supply and gets to go through the liver or the kidneys, wherever it's metabolized, to actually for the body to get rid of it. So I guess the reason I bring that up is that some medications, you need to consider the fact that this lipophilic medication is going to get spread out all over the body, especially with an obese patient with a ton of lipids, right? Whereas a hydrophilic medication, like you were saying earlier, your lungs aren't going to change size, your heart, your blood vessels, an obese patient still has 5 liters of blood just like you and me.
Yeah.
Right? Yeah. And that hydrophilic medication is going to just get dissolved in the blood that you put into the IV. It's just going to go into the blood and stay there.
And we're going to do a whole other podcast on this because it's important to put this in ditch doctor talk, right? Street paramedic talk is what does this matter for us, right? Ideal body weight, everybody's heard ideal body weight versus actual body weight.
Yep.
When do I change my dosing based on the size of my patient, or when should I use ideal body weight?
Yep.
And break it down real simply. If it's a hydrophilic water, it likes water, you want to use ideal body weight.
Correct.
If it's a lipid or fat liking medication, lipophilic, you want to use the actual body weight, because that will have a huge impact. Like if you're trying to take somebody's airway, you got to make sure that the medications you're giving, you're dosing them correctly, so that your patient is fully sedated, fully paralyzed in order to get the tube or whatever you're trying to do.
And if you're looking in the drug manual and you're looking for dosing, that's all based on ideal body weight.
Yes.
And so you have to think about these things.
It's very important. And like I said, we'll do a whole separate podcast. We're going to come out with a list and stuff of common medications just to make it simple, because it's complicated. And there's no way you're going to memorize it with all the things that we have to memorize. You know, it's just have a list, you can pull it out and just get to know those things. So
good.
So we talked about IV access, we talked about airway, the different challenges for pre-hospital provision. We talked about oxygenation. These patients have a higher oxygen demand. So you've got to be aggressive with your oxygen therapy. You know, if you're going to take these patients' airway, position them appropriately, get those high flow nasal cannulas on, get those, you know, if you're bagging them, you know, it's just they have a high oxygen demand, and so it's very important to watch what their SATs are doing, what their end titles are doing.
And I think to close this out, we talked a lot about patient safety with obese patients.
Yes.
Because there's a lot of things that we should consider.
Yeah.
But there's also the crew safety. There's you know, we got to really look after ourselves. You mentioned a few things, but these patients aren't normal patients. You're going to need to have a group of people potentially to move them around, whatever. So
that's true. So we'll talk a little bit more about that in the next part, and we'll talk about, you know, keeping their dignity, right? We don't want to be rude to these patients, right? We get it. Like you go on somebody that's 800-900 pounds and they've been laying in bed for 3 months or whatever. Like we still have to show them they're still human beings. We still have to be polite and do our job to the best of our ability and protecting their privacy and all those different things. So we'll talk more about that in the third part.
Yeah, we got a great story to tell.
In the third part or now?
In the third part.
All right.
Unless you want me to tell it now, I can tell it now.
No, I want. Let's build some suspense. All right, here we go. All right, so last part of our Obesity Patients podcast. This is the part where we're going to talk about protecting our patients.
Yeah, that's right, and not just their their safety, but also their dignity.
Yeah, their physical safety, but their emotional safety, their dignity, their privacy, all those kind of things. It's very important to do that, and that can be challenging at times.
My dad struggled with his weight his whole life, and I remember he was in the hospital once, and he was very sick, and I was in residency at the time, so I was wearing my scrubs when I got the call that my dad was in the hospital. I knew he was sick at home. He had the flu, and he got so dehydrated his kidneys shut down, and he got pretty sick, and so he decided obviously to go to the hospital. When he went to the ER, as a good son would do, I drove up from where I was in residency at the time, fortunately close to where my dad was. I went to the ER in my scrubs, and
you were going to show him. Listen, okay.
Right.
You see this? I got my white coat on. You see who I am?
You know, it's funny that the further along in medicine you get, the less and less you want people to know you're a doctor.
Yes, right.
But I love my dad, and I was there. I didn't waste time to change. I just got because normally I don't like to be in places with my scrubs on, but this was different. Yeah. So I got there and talking to my dad and making sure he's okay. He's getting admitted. Going to go to the ICU because his kidney function was not so good. The kidneys had shut down. And I wanted to go see some of the other blood tests and check out some pictures. They got a CT scan and they're doing other stuff. And so I went back to the doctor's area, and we're in scrubs with badges, and you look kind of official.
Nobody's looking at you like, who's this guy?
Yeah, so I was talking to our doctor in the doctor area and looking at some of the labs results and whatever. And these other doctors or PAs or nurses or whatever, they were on the side here saying some of the worst things about my dad.
Oh, no.
Oh, and it was heartbreaking to me to hear my professional colleagues speaking in this way about that obese patient in room 11. And to me, that I stood up for my dad and I told him, that's my dad you're talking about. I appreciate you showing some respect.
Yeah. Before I throw you through a window.
I mean, I was nice. They didn't know. And I've been there because in the ER sometimes we get these obese patients and we tend to, And I don't think it's any different in the firehouse.
No.
I mean,
it's probably worse in the firehouse, to be honest.
So,
Well, and because these patients also come in a lot. Like, they come into the ER. They call 911 all the time. So it's not just the fact that, it's an obese patient, but it's somebody that, like, because we're human, right?
Yeah.
Medical providers, we're human. And it's like, bro, like, take some control of your own life.
Yeah.
And so that can be very frustrating when you're constantly running all the time on somebody and everybody's telling them, look, man, you got to start changing your lifestyles. And they don't do it.
You're
and
right.
so that's creating more work for you. That gets frustrating. And that can lead to these situations.
Exactly. What's interesting, and this is not the same with everybody, but every individual has a story.
Yes.
There's all sorts of different sorts of trauma and all sorts of different reasons why obesity might manifest in a patient.
Right.
I can say from my dad's perspective, the reason he's been obese, and obviously we talked about this, and he wouldn't mind me sharing this, and unfortunately it's to a lot of people, but is that he was so advanced in school that he skipped a bunch of grades. And he ended up graduating and going to college at age 14. Like, he wasn't even able to drive when he went to college. Anyway, my dad tells the story better than I do. But when you're that behind physically with your peers, you really can't do sports. And so my dad never really had a chance. He loved sports, and he did sports, but he never got to really compete like maybe he wanted to, being behind everybody physiologically. Academically, he was advanced. My dad's the smartest man I know.
Yeah.
But my dad, my hero, really struggled with his weight. He never had, I don't think, this is my opinion, and we've talked about this, but never established those exercise sort of habits, things that he enjoyed.
Yeah.
My dad loved to ski, and he loved to water ski, and he loved to do active things. But when you start to combine love for food and lack of mobility, now my dad travels all over the world doing what he does. He's a healthcare expert. He is an amazing man. But when you're traveling like that, you're eating out all the time.
Yeah.
And my mom we're from Iowa, so there's no meat on the plate. It's a snack, right? It's like we eat a lot of good food.
Meat and potatoes and the carbs
rich
and
food, rich food. So all that to say, so my dad that's his history.
Sure.
And so the comments that were being made, a lot of people assume just lazy sluggards and all sorts of terrible things they were saying. And I had to straighten him out. It's like, my dad is not lazy.
Yeah.
He may not exercise like he should.
He's smarter than all three you combined. Yeah.
Right. And he's such a hard worker, too.
Yes. Yeah.
I could tell you stories.
Yes.
But anyway, all that to say, our patients deserve dignity.
Yes.
The jokes shouldn't be done.
No.
Don't care who your patient is or what it is. We should never joke about our patients. Sometimes I will say, though, that when a patient's getting coded and there's a funny tattoo or there's something we say that's crass, it's not meant to degrade a patient or whatever. They're even unconscious, but you have to be careful to always give your patient dignity. And sometimes in a code or a stressful situation, as providers, we may sound callous to the public if they were there.
Yes.
We walk a fine line with those things.
Yeah, because we use dark humor sometimes as a way to cope with some of the things that we deal with. For sure. And it's just an unfortunate reality of what it is. And it's never going to change. Yep. I mean, you can have whatever, that is never going to change.
Right.
So, I mean, it's just part of it. It's not meant to be offensive. It's more of us trying to cope with it. But another thing on your dad, the other thing, we don't know what people are going through. Like my dad's saying, my dad grew up in Pennsylvania, so it was the same kind of thing. But his genetics. Yeah. Now, my dad was a runner. He was big. He liked to run, so he did kind of have more of an exercise regimen. But my dad ate whatever he wanted and never gained weight. Yep. Right. So and that's kind of the same way I am. Now that I'm getting older, it's a little bit more difficult. But I mean. Yeah. For most of my life, I could eat whatever I wanted and I wouldn't gain a pound. Where you, as a bigger guy, you probably have always had to watch. Yeah. So, it's very easy for me to say, oh, well, you're fat and out of shape. Well, you might actually be eating a whole lot better than me, but because of your genetics and my genetics, I just stay thinner. And so that's another reason. Just because somebody's overweight doesn't mean that they're lazy or, their genetic makeup, they might be a vegetarian or whatever, eating really healthy and trying. And so we never know what somebody else is going through. Be mindful of that. Certainly don't embarrass your patient. while you're, while you're handling them and dealing with them. Don't do anything that would embarrass them. That's super important because, a lot of times they're living in apartments. If they're upstairs, we're having to get chairs out or, different things to move them. And that is, I've had patients that you can tell they're visibly embarrassed by the fact that this is happening to them right now.
Right.
That we're on the third floor of an apartment complex and we got to get out the stair chair because they can't walk.
That's right.
And so now we've got to take them down. And so it doesn't cost you anything to be nice and kind to somebody.
And I think, and I really believe that we should probably we should always make an effort to try to empathize with our patients.
Yeah.
Here we are in their home. We just had to tear the door apart so we can get them out of the room.
Yes.
Just think about how hard that would be to watch. It's like,
yes.
Now my problem's really public,
yes.
and then I, in the privacy of my own home, and this is a mess, and this is this. I couldn't get to the bathroom.
It's just
in time,
one more thing. I'm overweight. I'm out of shape. I'm not happy. I'm depressed. Nobody loves me. People make fun of me. Now I had to call 911, and they had to come in, and because I'm so big, they had to take the door off or cut a hole in my wall or whatever the case may be. And it just compounds the problem.
Remember when we talked, we had a podcast we did not too long ago, we talked about verbal de-escalation. And I think that SAVE mnemonic it works across the board.
Oh, yeah, for any patient.
Supporting is the S. Yep. Showing it's an honor to serve you today.
Yeah.
I'm sorry this is happening. I'm sorry that you're feeling well, and then acknowledging it. It's like I can see this would be very difficult if it was me in this situation. I'm so sorry we tore your door off to get you out of this room. That must be really tough. And then validating it, right? I would feel that way too. I'd be very embarrassed, and I just want you to know we're here to serve you. We're part of your team. Everybody here wants to help you. And then emotion naming is the E, and being able to say to that patient, you know what, I can see that you're angry, and I would be angry too. This is really difficult.
Yeah.
Anyway, so that SAVE mnemonic, I think,
can go across the board.
Right. We kind of gave it credit just for verbal de-escalation, but I think it's good with any patient.
Yeah. For sure.
I think it's especially here, these patients that are experiencing something really embarrassing or really tough to experience and being sick on top of the social stigma. Yeah. They need to hear us do those things.
Yeah. Oh, it's very important, for sure.
Huge.
Yeah, we got to be mindful of that. So, and then, you get to the hospital, you like I say, you might have to call out. We've had situations where we've had to call out a bariatric ambulance, to transport those patients or the cots or just, anyway, be mindful of that.
Yeah, and I think a couple more things that we should probably talk about. I like crash worthiness.
Crash worthiness?
These patients, very unsafe
that kind of
if you have a bad, you fall off the cot.
That kind of. I thought you meant crashing like coding crashing.
Oh,
you mean crashing
I
like
guess
actual,
that too.
Yeah,
it's like
NVA crashing.
Yeah, these patients they carry there's some difficulties in treating diseases. I mean, chest compressions are not going to be as effective.
No. You're trying to push through a lot more tissue,
and they may not even fit the whatever you're using.
Lucas device or whatever.
Device. Yep. So there are a lot of different factors at play here for patient safety.
Yeah.
And when you bring them to the hospital, that what we have in our notes here was the system readiness. So not all EMS systems have those bariatric beds. Yeah. Not all systems have
CT scanners.
Right.
Like
we talked about that before. Yeah. CT capabilities, not just weight but dimensions. We talked about.
Right.
So anyway, they're taking care. It's hard enough to get woken up at 2 a.m. to take care of it. The EMS call comes out, right? But then when you have the extra efforts that we have to go through and challenges of taking care of a 500-pound or 600 whatever pound patient, it's harder to have a good attitude.
Yeah. Especially when that person calls every night at 2 a.m. Right. Or, multiple times. Yeah. It's difficult. Really easy to lose your patience. Like I say, we're all human, right? And that it's really easy to lose your patience. So just, take a deep breath, go through it, and do what you got to do. But it's always important for any of our patient populations. We've talked about special needs, obese patients, homeless patients, patients that suffer with addiction or alcoholism, all these different things that are a large majority of our calls as first responders, right? We deal with patients that don't take care of themselves a lot of the times, and that can be frustrating.
And we deal with rude patients. We deal with patients that are totally disrespectful and say awful things to you.
Yes.
And they may be obese. They may be a transient. They may be one of these patient populations.
And it's kind of like your mama told you. Just if you don't have anything nice to say, just don't say anything at all. Yeah. We're not saying that you have to sit there and be like, okay, while somebody's cussing and screaming at you, but just don't say anything at all. Yeah. Just get them on the cot.
Do your job.
Do your job. Get them to the hospital. Whatever you have to do, just keep your mouth shut and move on. Because those will be the same patients that will complain on you too.
You know, we talked about the SAVE acronym as being good for all patient populations. I think this is another thing to remember. And I love to think about this as a husband, for example. When there's a tension in the marriage, and when you say you love your wife in the midst of tension, or maybe things aren't going so well, and you choose to say I love your wife, or you choose to even be kind, or whatever it might be, that's a better measure of a husband, I think. Because when things are going really well and you're at Disney World, it's easy to be that good husband, maybe, right?
Yeah, when you're drinking margaritas on the beach, everybody's happy. Yeah, exactly.
And I think the same thing is true here. It's almost like across the board in life.
Are you saying I should tell my patients that I love them? What are you getting at here?
Just drink tequilas. No, what I'm saying is when you have that difficult patient population that you're treating, let's just say because we're talking about obesity, you get that 600-pound patient that you've seen a bunch of times, just keeps calling 911, and you're frustrated. You could feel that you're right. That's an opportunity to have a good attitude and to try to be a positive sort of a paramedic, an optimistic patient, a provider. Remember, we talked about this at the beginning. Pessimism is actually bad for your health. If you can find a way to be optimistic in these patient situations, whether it's whatever the patient demographic is, if you feel yourself getting a little angry, that's an opportunity for you to really be a good paramedic or EMT or whatever.
Focus on your job. Focus on the good. Like, I just had 4 days off. I'm about to get 4 more days off. They're paying me right now. They're paying me.
That's right. Sometimes we got to think that.
Right? Yeah, exactly. Like, this is what you kind of signed up for, so try to find the good in it,
I love being a doctor when my patient says something like, man, you're the best doctor. I just love you, Dr. Axine. And it's easy for me to treat those patients nice.
And speaking of the nice thing, just one last thing, is I have found in my career that you could be not the greatest paramedic in the world, but if you're nice to people, you're never going to get complained on.
Yeah, it's true.
You're never going to get complained on. Where I've had paramedic partners that were phenomenal, very good clinical paramedics. They could start an IV on anybody, but they were always rude to people, and they would get complained on all the time. On the flip side, I've worked with guys that were not that good of paramedics, right? But they were always nice to people, and people loved them. And so for no other reason than just to alleviate complaints and problems, just be nice to people. It makes it so much easier.
Here's a great story. You got 2 guys. One guy graduated at the top of his class in sales. The other guy was kind of just mediocre. Right. The guy at the top of his class in sales gets to his first sale call ever, gets to the door, guy slams the door in his face. He's crushed, he quits. He gets the other guy that was kind of mediocre, door gets slammed in his face. I've faced adversity before. I'm going to go to the next door and the next door. He doesn't give up, right? And then he becomes successful. I think the same thing is true as a provider. I don't care what your test scores are.
100%.
That's like weight room strong. I've seen football players that can't perform on the field. There's weight room strong. Well, I think the same thing's true in our field. That's a good story. I think that the same is true though with us, because I think that people underestimate the power of kindness, especially in a patient interaction. If a patient feels safe around you, they're going to give you more information. You get more information. You get a better diagnosis. You provide better care. That patient interaction where you've built trust and communication is huge to patient care. So and it has been proven one of the best ways to defend yourself from a lawsuit, in medicine at least, is studied, is to have a patient experience that's positive. To have high press gainies.
That's what I'm saying.
Best thing you could do to not get sued.
So if you don't want to get sued, be nice to people.
That's not quite what we want.
That wasn't really our take home, but that was the last part of our.
But the obese patient can be difficult.
They can be in a lot of different ways. Physically moving them, they might be angry. There's a lot of different factors that play into how they can be difficult patients to deal with. And so in the midst of that difficulty, just, try to keep your cool. be nice, and move on.
And I think this was a great discussion about the anatomic challenges, physiologic challenges,
treatment challenges,
size, and all that, and the stigma. These patients deserve dignity just like anybody else, and they have disease just like everybody else. They need care. They called 911 for help, and we need to deliver that care in an excellent fashion as best we can.
Agreed. See you in the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.